Hello. Hello.
Hello.
Good evening.
Good evening.
How's everybody? Sorry for being late.
Please, you are fine. How about you?
I'm also fine. Okay, so can we do something? Is Hillary around? Can you tell the rest to join? Is Hillary around? Hello.
Hi.
Is Hillary around? So can I start?
Yes, please.
Or Hillary is not part of your group? Hello, Hillary.
Please, she's part.
Are you part of this group? But you are not. Okay. Can you tell the rest to join? Okay. I'm starting. Okay, so the last time I said I'll be doing what? I'll go back to I'll do the classification. Is that not so? I said I'll be doing the classification.
Yes, please.
So who can tell me? So NYHA, New York Heart Association classification. Who can tell me the classification?
Dr. Taka, please. We are not. I don't think we are done with the medications. We've not done the goxin and SGLT2
I know.
inhibitors.
I know. Huh? I know, but let's quickly do that. So let's do that. I'll go back to the go back to.
Yes, please.
We left with about 1 or 2. The goxin and ARNR. You know ARNR? Do you know ARNR?
Yes, please.
What is that? What is that? What is ARNR?
Angiotensin receptor neprilysin inhibitor.
What? The N is what?
Neprilysin.
Okay, neprilysin inhibitor. Okay, so quick on the New York Heart. That is the commonest classification I use. The Canadian ones are not much used. So now everything is America. So the commonest one that we use, the classification is the American classification, New York Heart Association classification. So you could be asked about the classification and ask you about the staging. Ask you about the staging. So if you are at stage 1, normally, just to make it simple for you, you talk about the limitation. The limitation is the symptoms, and you talk about when a patient is having activity limitation. So these two things should be in your mind. You have activity and you have limitation. This activity, will it give you a limitation? And that is that. So limitation will be linked to, normally they associate the limitation to the symptoms. Is the patient going to experience any symptom or any episode of heart failure with this type of activity? So New York Heart Association classification, we have stage 1. So for stage 1, there's no limitation or no symptoms with ordinary physical activity. Ordinary physical activity such as maybe climbing stairs, walking. These are ordinary activity. When a patient is doing such activity, there won't be any limitation or there won't be any symptoms. The second stage is we have slight limitation. There will be slight limitation with dyspnea. Normally, it's the dyspnea that we think about. When we are talking about the limitation, it's the dyspnea that we talk about. So slight limitation with dyspnea. So in terms of activity, there will be moderate to severe exertion. So when you have moderate to severe exertion, then you'll be getting slight limitation. Please, is it clear?
Yes, please.
So now we come to stage 3. And the stage 3, Hillary called me and was telling me that last time he said you'll be doing classification. I'm doing classification. And someone said, we haven't finished. Hey, rather. We haven't finished the medication. Do the medication for you. So for stage 3, please note these things. You can be asked, you could be given the activity and the limitation. You can ask of the class, you ask you to classify it and also stage it. So note what happens. First one, no symptoms or no limitation with ordinary physical activity. Normal activity, walking, climbing steps and pool. Second one is that you have severe exertion with limited activity. So we have severe exertion. When you exert yourself severely, there's a slight limitation, slight. Now you put in so much, there will be a slight limitation. Now the third is we have marked limitation of activity with ordinary activity. Now there's a marked limitation with just normal activity that the patient to be doing. And the small thing that the patient to be doing, then you see the activity, the limitation will be pronounced. Small thing, then the symptoms will be pronounced. The fourth one is that the severe limitation, even at rest, when the patient is not even doing anything, even at rest, there's severe limitation. So basically, this is the New York Heart Association classification. So back to the medication. I just want to say that for heart failure, now somebody will ask, I can't remember the last group, somebody asked us, how do you, if a patient comes, heart failure patient comes, how do you manage? Please, in essence, if you are asked to manage, asked to manage a patient, you have to think about pharmacologically and non-pharmacological. So think about non-pharmacological. As if a patient, heart failure patient comes with severe limitation, decompensated heart failure, how do you go about it? When you think about non-pharmacological, patient comes, think about giving oxygen, think about propping up the patient. These are non-pharmacological. Pharmacological, the first thing that you should look for is the IV laxes, because the patient becomes dyspnea. So you cannot give your tablets, your ACAIs, you cannot give your beta blocker when your patient cannot breathe. So quickly go in using your IV laxes. And when the patient is stable, then you can go in with your ACAIs, beta blocker. Beta blocker should be given when the patient is stable. Patient is stable from any palpitation, from difficulty in breathing. The patient is dry, then you can go in with your beta blocker. Stable heart failure, going with beta blocker. If you can introduce spironolactone to your patient when you stage it, and from stage 2 to stage 4, any of this stage, you can add your spironolactone 2 to it. So if the patient is on these medication, the patient is not getting breakthrough, still the contractility is going down, you can come in with your digoxin. So 4 pellets. Heart failure depends on these medication. We term it as 4 pillars of heart failure. So number 1, you think about beta blockers. Number 2, you think about angiotensin receptor. Let me see whether I can do that board. So beta blocker, we have the beta blocker, we have the ARNI. Try to see whether I can get a board. So we have the beta blocker. Please, can you see? Can you see the board?
Yes, please.
We have the beta blocker. So we have we have the A, R, N, R. So 2, 3, we have the mineralocorticoid receptor antagonist. Mineralocorticoid receptor antagonist. What is that? Mineralocorticoid receptor antagonist. The fourth one is SGLT2 inhibitors. The fourth one example is what? The fourth.
Dapagliflozin.
So we have dapagliflozin. So these are the pellets. Heart failure depends on these. Depends on these 4 pellets. Okay, so let me talk about this. Let me talk about the AR. ARNI. So AR. ARNI. We have this. And it's now we have this. This is 1. This is also 1. So example of ARNI is what? Example is what?
Sacubitril valsartan.
So we call it what? Upero. So we have valsartan. So the valsartan is this. And sacubitril. Sacubitril is this. What is the action of this sacubitril? It does what? It does what? Sacubitril is equal to NI. What is NI? Hurry up, please.
Neprilysin inhibitor.
What is that? What is that? Hurry up, hurry up. What is that? What is the function of the N? Neprilysin. What is the function?
The neprilysin breaks down peptides. So examples of the peptides are the atrial natriuretic peptide and the brain natriuretic peptide.
Mm-hmm.
There's also the C-type natriuretic peptide.
Mm-hmm.
So the neprilysin is responsible for the breakdown of these peptides.
So note this. Neprilysin has high affinity for atrial.
Yes.
Neprilysin has. You want to say something? Neprilysin has high affinity. Take note of this. High affinity for atrial natriuretic peptide and C-type natriuretic peptide. So atrial and C-type natriuretic peptide. But it has low affinity for B natriuretic peptide. So note this. N has high affinity for C-type and atrial natriuretic peptide, but low affinity for this. And so we realize that in heart failure, because there's accumulation of fluid, we need the NI. because the NI is there to clear the sodium and the fluid, will cause natriuresis. And this will aid, this will reduce the preload. And therefore, the load coming to the heart will be reduced by this. And because N is needed, we want to, this is acting like amoxicillin. It's acting like amoxicillin. So the N is preventing the sacubitril is preventing the breakdown of the N. So when you inhibit that, it means that the neprilysin won't have effects on the peptide. You inhibit this, will break down the A, and will break down the A and the C, and it has like less affinity for this. So when you inhibit this will be free in the system, and it can cause the natriuresis. That will reduce the preload. So the sacubitril will do that. And we have the valsartan, ARBs, valsartan, and this. So this is a newer preparation. So let me ask you this. If a patient is on ACEIs and you want to change his ACEIs to Upero, what will be the wash out time? How many minutes? How many hours? How many months will you wait for the change to be effective?
36 hours.
So 36, the wash out time is 36 hours. 36 hours. So please, I am begging you, common side effect you should know, please. And you should know the composition. Know the composition and know the amount. How do you give Upero? What is within? If you take the AR, what is within? Which strengths do we have at the market? Which strengths do we have at the market? Which strengths do we have at the market?
We have the 50 milligram and the 100 milligram.
What is the 60? What is within the 60 and what is within the 100? Please, you should know this. You should know this. So let me move on to the digoxin. Note the few side effects of the medication, please. So, digoxin, and take note of this. The use of digoxin in heart failure is debatable. The use of digoxin in heart failure is debatable. Because this drug is like beta blocker. This drug can also worsen the heart failure. But it's the best medication when you have heart failure with atrial fib. Heart failure with atrial fib is a drug of choice. Digoxin is a drug of choice, but it's debatable. We still use in heart failure. We still use in heart failure. But it's a drug of choice for this. So when a patient comes, heart failure patient comes with sinus rhythm. When I say sinus rhythm, what does it mean? When I say sinus rhythm, what does it mean? You understand sinus rhythm? Sinus rhythm, what does it mean?
The normal rhythm of the heart.
The normal rhythm is the sinus rhythm. So heart failure patient who comes with sinus rhythm, who is on diuretics, ACE. When you put the patient on digoxin, I'm saying sinus rhythm, normal rhythm. When you get atrial failure, it's not a sinus rhythm again. So heart failure patient who is on diuretics, ACEs, and digoxin, when you withdraw the digoxin, the symptoms will be worsened in sinus rhythm. In sinus rhythm, the symptoms will be worse. And there's we have a lot of studies that prove to that. We have radiance. We have proved study, and we have radiance study. This study talks about the fact that in sinus, heart failure patient with sinus rhythm, when the patient is on diuretics, ACIs, and plus digoxin, you withdraw the digoxin, the symptoms worsen. The symptoms worsen. You see effect of digoxin when we don't have sinus rhythm, when you have atrial fibrillation. When you have atrial fibrillation. And therefore, take note of this, and therefore, there's no measurable impact in terms of mortality. Digoxin will not reduce mortality. Digoxin will not reduce mortality. What digoxin does? Who can tell me what digoxin does? So, heart failure medication, I will ask you which ones will reduce mortality, which ones will reduce hospitalization, which combination will reduce hospitalization. Good. What does digoxin do in heart failure patient? Can you hear me, class?
Yes, please.
Yes, please.
What does digoxin do in heart failure?
It decreases hospitalization.
It decreases hospital, reduces the number of hospital admissions and hospitalization. So this is that's not in the area of mortality. It does not reduce what? Mortality. So good. Another thing that you should know is that digoxin, two functions of digoxin. It's important for you to know. Did you do arrhythmia at school? Did you do arrhythmia at school? Class, did you do arrhythmia at school?
No, please.
I wasn't expecting a positive answer. So I was not expecting you to tell me, yes, please. You did. So digoxin mechanism, we have two mode of action for digoxin. So one is to increase force of what? Contraction. Force of contraction. And two it reduces. One is force of contraction. It increases force of what? Contraction. Logotonic, it has a logotonic effect. It increases force of what? Contraction. Positive inotropic effect. And it's the second mechanism of action is to reduce impulses. Reduce impulses. Transmission from sinoatrial node to AV node. There's impulse reduction done by Lexis. So if you have the heart to be this, you have sinoatrial node, AV node here. Digoxin reduce impulse transmission. Digoxin from this side to this side. To also increase the force of what? Contraction. Force of contraction. These are the two modes of mechanism. That is why when a patient comes heart failure with atrial failure, when you say atrial fibrillation, I'll talk about that later. But we have so much impulses from the atria. So much impulse. When you say fibrillation, we have so much impulses from different areas of the atria getting into the sinoatrial node. So impulses from many parts of the atria. These areas will be releasing impulses apart from, in addition to what the sinoatrial node will be releasing. So this side will be releasing, this side will be. So we say it's fibrillating. That's fast chaotic impulses. When you say fibrillation, it's a fast chaotic what? Impulses released from different foci in the atria that is fibrillating. So when you give digoxin reduce these impulses getting into what? The AV node. So the force of contraction is that it has a positive inotropic. It's a positive inotropic agent. It does so by increase calcium ions in the myocardium. It increases the availability of calcium within the myocardial cells. And it inhibiting so we have influx. So sodium ATPs. So I'll talk about arrhythmia. I'll do the arrhythmia with you. On the surface of the myocardium, we have these channels. We have sodium channels, we have potassium channels, we have calcium channels. So the sodium channels, we call it gated channels. It's called gated channel because it can be open and closed. And you use ATPs. We use the ATP because we need energy to open and close these channels. What it the digoxin does is that digoxin will inhibit sodium, potassium ATPs, meaning it will close the sodium and potassium, and it will open up calcium. So there will be influx of calcium into the myocardium. And therefore, if you have enough calcium and you have enough sodium, so then there will be sodium and calcium exchange. This sodium and calcium exchange will enhance the contractility. So this is what digoxin does. When it's enhancing that, meaning that it will increase cardiac output. It increases cardiac output. It increases cardiac output. something that you have to know. Something again that you have to know. Digoxin is also associated with both vagal stimulation. Vagal stimulation and reduction. Digoxin is associated with vagal stimulation and reduction in sympathetic nerve activity, sympathetic activity. So if it's for it's associated with vagal stimulation, and therefore it can worsen the heart failure. What is vagal stimulation? Please, is it clear up to this point? Please, is it clear up to this point?
Yes, please.
So, last time I set a question on digoxin, and I was asking about this. If these are MCQs, digoxin is part of medications that comes with has low therapeutic index. So at times, the question we ask, all these medication has low therapeutic index, except so digoxin has 1, and you should know the serum concentration that we can safely work. Because if a drug has a narrow therapeutic index, it means that potentially it's dangerous to use. So another thing that you should know about digoxin is that if a patient comes with heart failure, with renal impairment, and liver impairment, which tell me renal impairment, liver impairment, which cardiac glycosides will you consider? Will you be saved in renal impairment? Which cardiac glycoside will be saved in liver impairment? I'm asking you. Hey, are you there?
Yes, please.
Tell me. If a patient comes with renal impairment, liver impairment, which cardiac glycosides will be saved in liver impairment? Which one will be saved in what? Renal impairment. Please find out this. Find out this. Find out, please. And again, there are certain conditions that you cannot use what? Digoxin. When a patient comes with those conditions, you shouldn't consider what? Digoxin. Certain conditions. So who can tell me 1 or 2 conditions where when a patient comes with that, you shouldn't consider digoxin? You should normalize stabilize the patient from that condition before you raise or before you initiate digoxin.
So within hypokalemia.
So we have good. We have hypokalemia. What again? What again? Hypokalemia.
Also have hypomagnesia.
Hypomagnesemia. Hypomagnesemia. What again? What again?
Please in low oxygen states where there's hypoxia.
So hypoxia. 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 What again? Then you ask yourself.
Hypercalcemia.
So called hypercalcemia. Good. Hypercalcemia. What again? What again?
Hypomagnesemia.
We have talked about hypomagnesemia. We have talked about hypomagnesemia.
Alkalosis.
So alkalosis. Any other? Alkalosis. What again?
Hypothyroidism.
Good. Hypothyroidism. So we have alkalosis. Alkalosis and please, these small things, note them. Alkalosis. Don't learn for as if it's for the exam, but let it be part of you. And you should appreciate. If I ask you how in hypokalemic state, you shouldn't consider the goxin. You should be able to explain. And the moment you mention hypokalemia, hypomagnesemia should follow. Hypomagnesemia should follow. So these are about 6 conditions: alkalosis, hypothyroidism, hypoxia, and cold. These are about 6 conditions which, when you are introducing your digoxin, you have to be careful. Then, what you should know about the digoxin. Digoxin, because digoxin, I told you this, digoxin would, one of the mode of action would reduce impulses transmission from sinatral node to AV node, and therefore digoxin, and as one of its side effects could have a cardiac side effect. Cardiac side effect. Let him tell the question that I said. One of my professional exams questions. I said you should state 3 non-cardiac side effects of cardiac side effect and 2 cardiac side effects of digoxin. Non-cardiac side effects and cardiac side effects of digoxin. Cardiac side effects, non-cardiac side effects of digoxin. So can you tell me non-cardiac side effects? So please note the side effect of this, of digoxin, and don't lump them together. Heart-related side effects, you put it down. And non-cardiac side effect, you also put it down. One of the cardiac side effects will be what?
Arrhythmias.
So you can quote bradycardia, which bradycardia is what? It's a form of arrhythmia. So bradycardia. What again?
Can cause second and third degree heart block.
Can cause second and third degree. What is second degree heart block? It can cause heart block. Can cause heart block. What is second degree heart block? Oh. Sanoji. What is second degree heart block, first degree heart block, and the third degree heart block? Okay, so any non-cardiac side effect. Any non-cardiac side effect. Any non-cardiac side effect. Yes.
Nausea.
Yes. Papa. Okay, so please note, I keep on telling you about these common side effects. The digoxin affects vision, can cause nausea, cause vomiting. So you should know this. Put about 3 for common ones in there. Any question? I'm jumping to gout. Any question? Shall I move on to gout?
Yes.
Okay, thank you. Okay, gout. So, gout is a form of arthritis. And these arthritis, well, this was affecting, or 99%, affecting the rich people. Thus, gout, it's a form of arthritis, was affecting the rich people. So we're calling this gout arthritis of the rich. Arthritis of the rich. Because there's association between gout. There's association between gout and food. Raw food and alcohol. And you should know the type of food that could cause this. The type of alcohol. So we have beer. Beer contains more purine. And rich people, in the olden days, rich people were able to afford this beer. You see them with the beer. The moment you see people nowadays, it's common. First, to buy beer is only rich people. And the rich people can buy meat. A rich man can buy a whole goat. Nowadays is common. First, it was difficult to see people drinking water from these bottles. Now it's common. So when you are saying this, you won't. Now it's common. Everybody is drinking from the bottle. First, we're drinking it from they have some rubbers which they blow air into before they fill it. They call it opening or something. Then sachet key, and then these bottles. Okay, so rich people were using, when they come from outside, they'll be using the bottle. You'll be seeing colleagues carrying their bottles when they are going to town. So things have changed. Now gout can affect anybody, but first it was affecting the rich people because of association of gout and food. There's association with gout is associated with certain foods and alcohol. So we term it as arthritis of the rich, arthritis of the rich. So when you talk about gout, okay, let me, after saying this, please hold on for me. Hello. Hello.
Hello.
Hi.
Sorry. So gout and hyperuricemia. What is the difference between? So when we say, what is the difference between gout and hyperuricemia? Hurry up. So when you talk about gout is, we say, is an inflammatory joint disease. Gout is an inflammatory joint disease caused by hyperuricemia, high levels of what? Uric acid. When you talk about gout, it's a common inflammatory joint disease. And this is caused by deposition of monosodium urate crystals, monosodium urate crystals. Within that will deposit within the joints and soft tissues. So gout is a common inflammatory joint disease caused by deposition of monosodium urate crystals in the joint and soft tissue following chronic hyperuricemia. When you talk about hyperuricemia, it's just higher levels of uric acid above the normal range. That is hyperuricemia. When you talk about gout is a clinical manifestation resulting from this hyperuricemia. The position of this uric acid within the joint causing damage. When it does cause damage, it becomes gout. So if you have calcium crystals, calcium phosphate crystals causing damage to, causing arthritis, how do you term this? Is it a gout? Is it gout?
It's called acido gout.
It's called pseudo gout. It's not gout. For us to call it gout, take note, it should be hyperuricemia. It should be uric acid. If you don't have uric acid, anything that causes arthritis is a pseudo. We don't call it gout. Uric acid causing damage to these joints will be termed as what? Will be termed as gout. If it's uric acid, if it's other crystals, we call it pseudo gout. We call it pseudo gout. So note this. So a patient will come with hyperuricemia. A patient will come with hyperuricemia based upon two disorders. There could be disorders of purine metabolism. So purine metabolism. And this purine metabolism will give us either disorders of purine metabolism. And these disorders of purine metabolism will cause hyperuricemia due to these two conditions. One, or A, it could be under secretion of the uric acid. Under secretion of the uric acid, or overproduction of the uric acid. These disorders, purine disorders, could lead to under secretion and overproduction. So you can look at which condition will cause under secretion of uric acid, which conditions will cause overproduction of uric acid. Please, is it clear up to this point?
Yes, please.
Yes, please.
Can you tell me one condition that will cause under secretion and one condition that will cause under secretion overproduction of uric acid? So these two situations could lead to hyperuricemia. Condition, hurry up. Under excretion. Oh, Which condition will cause under excretion of
His renal insufficiency.
so renal and
Me and Dad rejected this from the morning, and now you're giving me the same food.
Please mute. So this is just epidemiology, few small epidemiology. So gout predominantly affects men. It affects men more than women. And the ratio is about 3.6 is to 1. 3.6 is to 1. 3.6 is to 1. Is to 1. So let me make it approximately 4 is to 1. So men are exposed, but of late, the way the women are chasing men in terms of alcohol, in terms of the meat, is becoming equal. Yes. We're seeing the women also taking alcohol. But normally, it's the woman. It affects the woman. But when they have these menopause, when they develop menopause, at the menopausal period, they normally have this uric acid deposition or hyperuricemia. So you'll be seeing them experiencing this gout after menopause. That is where the woman will get it. So let's talk about the pathophysiology of gout. Pathophysiology of gout. Gout is normally caused by anything that can produce this purines, anything that can produce the substance purine can cause gout. The patient have that risk of getting the gout. So if I ask you, purines can be obtained from where and where and where? Tell me where purines can be obtained from. Tell me where.
Red meat.
So if you are talking about red meat, it means from diet. From diet. So alcohol will also be here. Alcohol will also be here. Where again can you get purines? Ariel. Purines can also be obtained from cellular nucleoproteins. So breakdown of cellular proteins, like we have DNA and RNA, cellular nucleoproteins, and can also be obtained from the purine nucleotides. Synthesis of nucleotides from, when I say from de novo, when I use the word de novo, do you understand? So cellular nucleoproteins, cellular cells, nucleus, what is within the nucleus? Nucleotides. What are the nucleotides? It contains something which will produce. So we have purine nucleotides, and you have these. These are 3 areas. These nucleotides are produced by the body. The body will start, and you call it de novo. Start. It's the body that will start from the beginning. So synthesis is by de novo, means that the body will start the synthesis. So synthesis of RNA, synthesis of DNA, this is done by the body. So note this. Purines are obtained from these. Purine nucleotides. The synthesis is de novo, breakdown of cellular nucleotides, and from the red meat and diet. 1/3 of purines are produced from the diet. 1/3 of these purines are produced from the diet. So let's see how this is done. Let's see how the production of uric acid is done. So let's see. So I said that we have. So these purines from either from the diet, either from the cellular nucleoproteins or purine nucleotides. All these will be broken down to what we call, I don't know whether I should start from there, but I'm starting from the top. Because at school, we'll be starting from purine to hypoxanthine. But let him go up a bit. So these purines within this will be converted to what we call inosine. Inosine monophosphate. Inosine monophosphate. So we have this. We have, let him say, the de novo, the purine nucleotides. We have de novo. De novo is where the body would produce the purines from the beginning. So they produce purines from a substance called ribose 5-phosphate. Ribose 5-phosphate. Don't know whether I should, because at times we will go back and be talking about this phosphate. Ribose 5-phosphate. And there's a cellular, I'm not fast in writing using this, a cellular nucleotides, cellular nucleoproteins. These are cellular nucleoproteins. The breakdown of these cellular nucleoproteins will also give us this. So we have the body producing purine, starting, that is why it's de novo, using ribose 5-phosphate. and that will produce this. Cellular nucleoproteins. Cellular nucleoproteins. Breakdown of this DNA will also produce inosine on the phosphate that contains purine. And this will also produce inosine monophosphate. And it's done by a long enzyme. Long enzyme. Let me write the enzyme because it's important. Take note of this. The breakdown of these cellular nucleoproteins will give us inosine monophosphate. And when we have more of the inosine monophosphate in the system, because some are producing from here, some are producing from the diet, because the diet contains purine. And these purines will be converted to inosine monophosphate. Let's see. So we have diet also coming in. De novo from ribose 5-phosphate, that is from the system. The DNA and breakdown of these is also producing this. And therefore, when we have more of this inosine monophosphate, this is a reversible something. So when we have breakdown of DNA here, it will give us inosine monophosphate. When we have more of this inosine monophosphate, we have some going back into the cellular DNA. So we have an enzyme that will convert some of these inosine monophosphates back into this DNA. And they are long name. They are H, G, P, R, T. We call it hypoxanthine guanine phosphoribosome transferase. Hypoxanthine guanine phosphoribosome transferase. This ensures that when you have a lot of these inosine monophosphates, some are pushed back into this DNA. And therefore, if you don't have this enzyme, what could happen? When you don't have this enzyme, what could happen? When you don't have this enzyme, it means that when you have excess of this, there won't be any conversion from this to this. So take note of this. We have a syndrome that when a patient comes with that syndrome, the patient will be deficient of these enzymes, HP, HGPRT. When a patient is deficient of that, it means that when you have so much inosine monophosphate, there won't be any conversion from the inosine monophosphate to that DNA. So more of these inosine monophosphate will occur. Then what happens is that these inosine monophosphate will be converted to inosine. Inosine will be converted to inosine. And this inosine will then be converted to hypoxanthine. And hypoxanthine will be converted to xanthine. Then this will be converted to uric acid. So hypo to xanthine, we have xanthine oxidates. And xanthine to uric acid, we have the same xanthine oxidates. We have this. So school, we will not be touching on this side. I'm touching on this side because from here, from ribose 5-phosphate, we have enzymes that will convert ribophosphate to inosine monophosphate. We have enzyme here. So if it's by default, genetically, if a patient comes and is not having these enzymes, it means that there's another thing. If a patient is not having these enzymes, will convert ribose 5-phosphate, it's another thing. If a patient is not having these enzymes, it's also another thing. So take note of this. This same enzyme, the HGPRT, same enzyme is responsible for this inosine to hypoxanthine, and this enzyme, the same enzyme, is responsible for that. Therefore, if you lack this enzyme, call it. I'll be asking you, which syndrome, when you lack this enzyme, which syndrome will it produce? There's a syndrome. To produce a certain syndrome, and I ask you the name. So this is basically how uric acid is formed. Uric acid, purines are obtained from de novo. The body will produce purines from this purine nucleotide from ribose 5-phosphate. And there's a cellular breakdown, the DNA breakdown. And this DNA breakdown also produces purines. And these are converted to the first state as inosine monophosphate. So inosine monophosphate will be obtained from here, that here. And these inosine monophosphate will be converted to inosine. And inosine will be converted to hypoxanthine. And hypoxanthine will be converted to xanthine. And we have uric acid. What happens is that in mammals, in animals will go ahead. Mammals will hit. So in human beings, let me use the word, in human beings, these will end at uric acid. It will end at uric acid. In human beings, this will end at uric acid. So myself and you, our system will produce uric acid. But in animals, they have an enzyme called uricase. And this uricase will convert the uric acid to allantoin. And this allantoin is water soluble and it will be excreted via the kidney. So it will be difficult for the animals to get this gout or hyperuricemia because of the uricase. And because of that, we have a drug. A drug that mimics the uricase. And they are used in oncology a lot. It's very expensive. That works like uricase. So because oncology patients will come with high levels of uric acid. Who can tell me why the oncology patient will be put on allopurinol and go why? Who? Hey, Class, can you hear me?
Yes, please.
Tell me, why is it so? Oncology people, don't you have any oncology students among you? Don't you have?
Please, we do.
So tell me, why do you give them oncology? Why do you give your patient allopurinol? Or you don't? You don't.
Chemotherapy can increase uric acid levels.
How will chemo increase the uric acid level? How will it do that?
It can cause an increase in uric acid levels due to the breakdown of the cancer cells.
Good. So, because of the breakdown of cancer cells, and the cancer cells, the multiplication is faster than the normal cells. So we have these large numbers of cancer cells. Breakdown of these cancer cells will now lead to this breakdown of this DNA. And this will release this purine. This contains purine. And therefore, there will be excess of purines in the system. So, can you tell me about 3 or 4 conditions that will cause? Let him tell you this. Let him tell you this. We have uric acid forming. Uric acid forming. The uric acid, this uric acid can hide in the system. You could be there and you could have more of uric acid hiding in your system. And this will hide, and certain situations can cause them to get into the bloodstream. Uric acid, certain situations can cause them to. So the formation of these uric acid crystals will be formed within the fibrous tissues. Hey, Radi. Hey, some of you are. Hillary.
Please, I'm trying to mute.
Okay, we'll try locum. The person is doing locum. I circle either doing locum or is looking for a transportation to. So take note of this here. Let him tell you one secret. The secret is that these monosodium urate crystals are formed within the cartilages and the fibrous tissues. They prefer to form here cartilages and fibrous tissues in the system. Why? Because when they are formed over there, they are protected. They are protected from these inflammatory mediators. These inflammatory, when they are formed within the bloodstream, inflammatory mediators can destroy the mesonym. So they are formed, they prefer to be in the fibrous tissue or cartilage. And over here, they are protected from these inflammatory mediators. When this happens, they can be in the fibrous tissue or cartilage for years, months. weeks without any distraction. So you can be there, and your system could have this. You have more uric acid forming within the fibrous tissues. And they can be there. When they are there, they will not cause any symptoms. They will not cause any symptoms. So they are shelled. If they are released from these areas and come to the bloodstream, then it can cause a damage. So, which condition can cause them to be released from the fibrous tissue or the cartilage into the bloodstream? What are some of the conditions that could push them from the fibrous tissue or the cartilage to the bloodstream? Who can tell me one or two?
Trauma, dehydration, or rapid weight loss.
Trauma, good. Trauma. What again?
Dehydration.
Good. What again? Trauma is one. Trauma can cause uric acid to be released from the fibrous tissue or cartilage into the bloodstream. Trauma. Dehydration. What again? What again? We have rapid weight loss. Rapid weight loss. And the last one is acidosis. Acidosis. When you have this situation, and I'm telling you this for you to know that the uric acid prefer, you want to go to abroad, you prefer to go to abroad than here, than stay in Ghana. Why? Because of the conditions over there. Uric acid formation, they prefer to form within the fibrous tissues and the cartilages, because they'll be protected from these inflammatory mediators. They can be there for years. So when you have any of these issues, acidotic situation, medium, we have rapid weight loss, dehydration, or trauma, will cause the uric acid to release from. And when they are there, they will not cause any symptoms. And then while they are in hibernation, they will not cause anything. So when they are released into the bloodstream, then you tend to cause. Any question up to this point? Any question up to this point?
No.
Okay, so note this. Note this. Note this. Oh, good. Hello.
Hello.
Yeah, so when uric acid gets into the bloodstream, we have uric acid. It has a solubility limit. It's soluble, but it has a limit. Monosodium urate has a solubility limit. The limit is 380 micromole per liter. When you exceed this limit, 380 micromole per liter, when you exceed this limit, then there will be crystallization. So monosodium has a solubility limit, and when you exceed this limit, then there will be what? There will be crystallization. Now, what you should know is that gout will be as a result of primary. Can divide gout as a primary. We'll have gout as what? As secondary. So primary or secondary. So for primary gout, when you say primary gout is that when you have an inborn errors. When you have inborn errors, this is genetical. Inborn errors could give us a primary gout. Inborn errors. Who can tell me one example of an inborn error? One example of an inborn error. Inborn error.
A deficiency of the hypoxanthine.
How do you pronounce it? So this syndrome is affecting the enzyme that we talked about. So when you lack this enzyme, the long enzyme that I talked about, when you lack that enzyme, it means that the inosine monophosphate, if you have excess of the inosine monophosphate, there won't be any. This enzyme will not be there to push it back into the DNA, into the cellular. And therefore, we'll have more of what? More of these inosine monophosphate to cause the production of uric acid. You could also have secondary, and that secondary could be due to drugs, or some disorders. Who can tell me one or two medications that could cause high uric acid?
Loop diuretics.
So loop diuretics. Any other?
Thiazides.
So we have loop, we have thiazides. Any other?
Aspirin.
Aspirin. So what about aspirin? Tell me. What about aspirin? So aspirin, we say aspirin has bimodal what? Bimodal effects. Bimodal effect means that we have low doses, higher doses. And low doses and higher doses will give you effects. So what will low doses present and what will the high doses present? If a question is asked, is aspirin a contraindicated in gout? Yes or no? What will the effect of high doses of aspirin, low doses of aspirin? Can a patient use low doses of aspirin? A gouty arthritis patient use low doses of aspirin.
Yes, sir.
Tell me. What will be the low doses? What will be the high dose effect? Can we use I'm listening.
So the low doses will increase the uric acid levels, but high dose will increase the excretion of the uric acid.
So it means you can't use low doses. A gouty arthritis patient cannot use low doses. Take note of this. The bimodal effect. Higher doses could be used. Certain medications. Certain. Hold on for me. So any other conditions we have talked about medication. Any other conditions that could enhance nucleic acid turnover? Any other conditions that could enhance nucleic acid turnover, the breakdown of the cells? The breakdown of the cells. Any other conditions? Any other? Rhabdomyolysis would affect the muscles. Any conditions that would affect, I wanted you to be telling me hemolysis, hemolytic anemia, hemolysis. You could also have what you call myeloproliferative. You could have lymphoproliferative. These are tumors, cancers. These are cancers. So any condition that will cause cell breakdown such that nucleic acid turnover in the bloodstream will be high will cause the release of more purines in the system. So when it's secondary, it could be due to medication. It could also be due to some disease condition. It could be primary when there's an inborn error, which is genetic inborn error. This, so you could be asked about secondary gout. What could cause secondary gout? Give 2 conditions that could cause secondary gout. Give 3 medications that could cause secondary gout. So please note this. Okay, this is where I got to the first group. So I'm ending it here. Today is what? Sunday. When do I meet you? Is it Wednesday? So I'll be meeting you on Wednesday. So good night.
Yes, please. Thank you.
Good night.
Good night, doctors.